CML appears to be driven by the BCR-ABL fusion protein. Tell us about these inhibitors of BCR-ABL. How many are there? What are the differences?
Well, the pioneer, the one that started all of these, is imatinib, a drug that we first got to know as STI-571, and this was a drug that started this revolution. It's what we call the first generation tyrosine kinase inhibitor. Then we have available today clinically three what we call second generation tyrosine kinase inhibitors, dasatinib, nilotinib, and bosutinib. These all have been investigated for the treatment of patients who have developed resistance or intolerance to imatinib, and they work effectively. They're more potent than imatinib. They cover most of the mutations that confer resistance to patients that have failure with imatinib. So they're all approved. These four, imatinib and the three second-generation tyrosine kinase inhibitors, are all approved also for initial therapy. And then we have our third-generation tyrosine kinase inhibitor. One of the things that we recognized was that some patients develop mutations that are insensitive to all these tyrosine kinase inhibitors, notably these T315I mutation. That led to the development of ponatinib, which is perhaps the most potent of the tyrosine kinase inhibitors, and it covers all the mutations that we know that can develop on patients with resistance to tyrosine kinase inhibitors. So that's our one third-generation tyrosine kinase inhibitor. Ponatinib is only approved for patients who have resistance or failure with other tyrosine kinase inhibitors. It's not approved or indicated at the moment for frontline therapy, but it is a very good option for patients with that need subsequent lines of therapy or who have that mutation.
Are they all equally selective for BCR-ABL, or are there differences?
There are differences. For example, dasatinib and bosutinib are also SRC inhibitors, as well as ponatinib has some activity against SRC. All of these drugs, except for bosutinib, inhibit c-KIT and PDGF receptor. That's why, for example, they work in GIST and in other entities that have PDGF receptor rearrangements, like some of the hypereosinophilic syndromes. Bosutinib wouldn't cover those. And then there are other targets. For example, ponatinib inhibits PDGF receptor. That doesn't seem to have any value in terms of efficacy, but it may correlate with some of the adverse events that we see, like hypertension with ponatinib. So there is a variability in terms of their profile of kinases that are inhibited.
So if these drugs are able to block the activity of BCR-ABL, why would it be possible for the disease to progress then?
Well, there are different mechanisms that have been identified. The one that we recognize best, and that's probably the most common, or at least the one that we find more frequently, is the development of these mutations. And what happens with these mutations is that there are changes, usually one codon, one amino acid change, that most of the time what they do is they prevent the binding of the inhibitor or maintain the activity of the kinase even in the presence of the tyrosine kinase inhibitor. Therefore, then the drug is there, but it's no longer able to inhibit the kinase activity. If you change to a different tyrosine kinase inhibitor that is able to overcome that does bind or that does inhibit in the presence of that mutation, then you can regain sensitivity. So in that instance, it is the fact that the kinase regains activity because the drug is no longer inhibiting. With the T315I that we mentioned, for example, this is a very bulky residue of isoleucine instead of the threonine at this 315 residue, and that prevents the binding of all of these inhibitors. And ponatinib, the biochemical configuration is such that it allows to bind even in the presence of that bulky residue. So that's how some of these work. We know of other mechanisms of resistance, much less well characterized. Some of them you cannot identify in the clinic. There's no good test for them. We know that it's been some description of SRC activation in some patients. The transporter that brings the drugs into the cell, something that's called OCT1, seems to play a role into that. But those have been mostly research questions, and there's no really good clinical test to tell you that. So really right now, mutations is the one, and that's how it works.